Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This week, we are talking to Cole Schaefer and Greydon Ratushny, who are both Canadian paramedics from British Columbia, places near and dear to my heart. I spent a year there myself. And they are pretty much on the cutting edge of trying to push things forward. So, gentlemen, welcome to the program.
Thanks for having us.
Yeah, thanks for
So tell us a bit about yourself and what you're doing.
Yeah, so my name is Greydon Ratushny. I'm an advanced life support paramedic from Vancouver, British Columbia, and I'm currently about 3/4 of the way through the master's program.
And yourself?
I'm Cole Schaefer. I'm an advanced care paramedic that gets all around Canada, for lack of a better word. Little less far on the masters, but so far so good.
Okay, for the listeners that don't understand the Canadian system, tell us how the BLS paramedic works and ALS paramedics work, and you guys are one above that.
Yeah, so in British Columbia, specifically Western Canada here, we have 4 different levels of paramedicine. We have the emergency medical responder, we have the primary care paramedic, the advanced care paramedic, and the critical care paramedic. So the EMR, or emergency medical responder, typically is found in most of our fire services and mainly focuses on life-saving interventions and transport. Above that, we have the bulk of our paramedics in British Columbia, which are primary care paramedics, and they can be found all throughout the province, both doing inter-facility work, 911 calls, some specialize and do air work, specialize and do community paramedicine. And then above that, we have the advanced care paramedic level, which is only found in certain major epicenters, more metro in nature, in and around British Columbia. And they're tiered and targeted to CTAS 1, CTAS 2 events, primarily focusing around resuscitation, cardiac, respiratory, major trauma, and high acuity events. And then the last level above that, we have our critical care paramedic level, which in British Columbia solely focus on being mobilized for the bulk of their work, air assets, both rotary wing and fixed wing. And we cover just under 1 million square kilometers in BC. And they do all of the high acuity transfers, as well as significant ground responses that would implicate lengthy transfers to major trauma centers. So they try to cut down on transport times, as well as also supporting a lot of our remote and rural hospitals in and around primarily central and northern BC, where there's not easy access to large centers of any sort of great capacity.
So Canada has a BLS paramedic, much like we have in Ireland, where they're not quite up at the ALS level. Tell us a bit about your background of how many hours is the BLS? What are they allowed to do? And then how many hours are the top 2 tiers of paramedic?
So in BC, we have, and actually across Canada, basic life support is considered to be our EMR, our emergency medical responder, and our PCP levels. Our EMR consists of a 3-week program with a license, then going through a licensing process. And that's where they can be found a lot in our fire service. Above that, we have our primary care paramedic level. They undergo approximately 3 months of online training, followed by another 3 to 4 months of in-class training, followed with a short practicum. Above that, we have our advanced life support level. And our advanced life support team consists of our ACPs and our CCPs. Our ACPs undergo approximately 2-year educational process that integrates them in with both practical time on the ambulance service, as well as dedicated OR time and ICU time within the hospitals, and a comprehensive in-class learning. Above that, we have our critical care paramedic level, and our CCPs undergo approximately 18 months of education and residency, and they get a lot of one-on-one time with the physician groups that really specialize in critical care and ICU medicine, as well as other niche areas such as neonatology and pediatrics.
We'll come back to that in a second, but I'm interested in a day-to-day. So, Cole, what does your day-to-day look like?
My work environment's a little bit different, though I reside in BC. Advanced care paramedics are branching out, as they are everywhere else in the world. And I spend a lot of time providing care in Canada's remote First Nations communities in the great far north in the Arctic, particularly the Inuit population. So due to a variety of external factors, there's no clinicians up north around the COVID times. So advanced paramedics were integrated in to help solve that staffing shortage. And then as the paramedics started doing the work that they do, it was realized what wide variety of skills they bring to a multidisciplinary team in these clinics. So my day generally consists of 9 to 5 sick call for the military folk or primary care, urgent care for the communities. However, because I am a member of a multidisciplinary team and I do have nursing colleagues who are better at the primary care than I am, admittedly, it allows me to focus on more acute patients and spending 4 to 6 hours trying to differentiate these complex cases in resource-limited environments, because my general evac times on a good day is 12 hours for a team to come and support me.
So you're clinic-based, you're not road-based.
The bulk of my work is clinic-based, and then I dabble on the ambulance on the side.
Okay. Greydon, what's your day-to-day?
So my day-to-day differs a little bit from Cole. I typically book on either an ambulance or an SUV. I'm based out of Vancouver, so our day looks remarkably similar to a lot of our primary care paramedic colleagues. We report to the station, do our vehicle checks, sign our narcotics, and then that's where things can really depend on how the day shapes out. Typically for us, we'll see anywhere upwards of on a Saturday night, Friday, Saturday night, we can see upwards of about 20 patient contacts. We are tiered and targeted, so we constantly are making it to all of these, or constantly responding to all these CTAS 1, CTAS 2 events. Given the nature of dispatching and medical call taking, sometimes we don't make it to the event. Sometimes the primary care paramedic crews cancel us before our arrival. On the events that we do make it, the expectation of the advanced care paramedic is that we do a rapid triage and assessment of the patient and really determine whether they need advanced life support care. If it's determined through the practitioner that they don't need advanced life support care, then we do a conveyance and we hand over to our primary care paramedic crews and really just help them build a clinical plan for that patient and management moving forward for their care. If it turns out that this is a sick, unstable patient, then we will retain care of that patient and move them and carry them with us to the hospital and do whatever advanced life support measures are required or resuscitations are required to get us from point A, the point of injury, and point B being a more appropriate tertiary care center.
So since you're the top tier, how many calls are you treating and transporting versus treating and release? Are you in a response car? Are you in a box? Or
so my current role has me in a response car, so an SUV. So that changes clinically my mindset a little bit, where I don't have the capacity to transport, and so now my threshold to move these patients changes ever so slightly compared to if I was working in a paired environment with another practitioner. But in the reality I'm in right now is I work by myself, which has its benefits and drawbacks. So I will probably be dispatched to 15 plus events. Of those 15 plus events, I'll maybe make it to 10. Of those 10 events, I will maybe carry approximately 2 to 4 of those patients to the hospital a day.
So is there a pre-hospital doc in Canada, or is that completely out of the picture?
To our knowledge, that does not exist. We have access to consultants on the road, and BC is actually very unique. We've got a paramedic-centered support system. Years ago, we determined that paramedics should be leading paramedics. Makes sense to me. So when we need help on the road, we can phone the support service and a senior critical care or advanced care clinician with additional training in hazmat and some other quirky things answers. And we can talk provider to provider to work through the problem and loop in an intensivist or an emerge doc or a pediatric doc into that conversation as needed. And it's been very successful because our physician group was very overloaded in the early days, because you have everybody from an EMR to a CCP that has access to these physicians and varying degrees of need with those phone calls. And then particularly for our air providers, we have a dedicated transport physician, which differs from it's not a transport medical physician like other services have that provides oversight on each specific transfer. It's more an ICU fellow or an intensivist who can answer our critical care colleagues' phone calls on very complex patients and provide almost colleague level support.
are you allowed to treat and release?
Yeah, so in BC, we're really trying to find alternative ways of getting patients the best care that they can have the first time. And so we've taken a lot of notes and strategies from our colleagues in Europe, in Australia, and have really been doubling down, so to speak, on virtual assessments and alternative care pathways. So we are starting to leverage in Canada, in BC, I should say, the utilization of urgent primary care centers, follow-up phone calls, referrals back to, or I shouldn't say referrals, but follow-up phone calls with clinicians 24 hours later through our clinical hub support system. We're really trying to equip our practitioners and all of our paramedics across all levels to be able to make clinically and evidence-based decisions and help support our patients to get the best care that they need the first time. So if that means that they need to go see urgent, or they need to be seen, but they need to go to an urgent care center, we can make that happen. We can either have that happen via virtual assessment with our clinical hub system, where they get either sent via a low acuity response unit, like in a minivan, staffed with a paramedic, or they can be put in a taxi and driven to the UPCC. And what we're really doing is we're making the best attempt to download some of the weight from the emergency departments and free up space for these high acuity patients or these medium to high acute patients that need to be seen that day, but really can be seen in an emergency room rather than a UPCC. And that's what we're trying to do, is we're trying to capture that patient population that can be seen by a physician or an MP, but they can go to a UPCC and have that done, freeing up space in the waiting room.
So for the times that you do transport, so EMRs and PCPs do most of them, how long are they queuing in A&E before they finally offload their casualty?
It depends on the day. It depends on the time of year. Where I'm at in Vancouver, typically in and around either the beginning of ski season or the beginning of mountain biking season, our A&Es, our emergency departments, back up considerably. So we can see considerable wait times. It's not uncommon to see some of these patients who need to be seen, who need to have imaging and need to be assessed, but are relatively stable. They can be waiting in excess of 4+ hours to be seen. We currently are working with our senior partners in the health authorities, as well as within the ambulance service, at a senior leadership level to have to lay policy down as far as how we're going to keep how the hospital is going to hold on to paramedics and how we're going to release those patients into the hospital's care, pending any sort of high acuity event in the community that's waiting for an ambulance. So, for example, if there's a CTAS 1 or 2 call that is holding in the community and that ambulance is sitting at the emerge department waiting to be offload this patient into a bed, there's pathways and policies in place that allow that crew to release the patient to the hospital in order to respond to the event.
That's brilliant. So you can turf off your biddy and
quite literally,
and just push her in the stretcher, kind of coasting towards the front of the A&E, and you.
In a roundabout sense, yes. There's a little bit more to it, but it really ensures that we as the ambulance service have the capacity to be able to respond in a timely manner to high acuity events in the community, which is really where our care is needed most.
And it's not to say we didn't have our struggles when we were students almost a decade ago now, I suppose. We, book on for night shift. Okay, go to the hospital, relieve the crew, and you'll sit another 12 hours with that abdo pain waiting for a bed. So we definitely have gone through the struggles that our colleagues in the UK are experiencing. And of course, we have no education on how to provide this austere emergency care sort of concept or prolonged field care in the hospital, because why would we ever have to do that? But thankfully, through the work the senior leaders have done within our organization, and it's been very successful in the last 2-3 years for sure. So
one of the articles that Tom Ellenson and I published last summer was a premise of adding prolonged field care to these waiting times, because in the UK, 14 hours is not uncommon. Is that something that you think prolonged field care for paramedics would be warranted in BC?
I think the application of PFC or prolonged field care has its place, not necessarily in the same context that our partners over at the NHS or other European healthcare facilities are seeing. I think that the role for PFC lies more in some of our remote and rural areas within BC, where the access to either to have aeromedical transport arrive by critical care or by road can be a little bit longer in duration. And that's where I think maybe there's an opportunity for a little bit of prolonged field care work to be done on some of these more lengthy transfers, or where we're waiting to have these patients picked up and have our crews supporting the local emerges.
So what do you suggest a way to do that, to introduce prolonged field care, austere emergency care in those communities?
That's a hard one to answer. There's a lot of working parts to that. And as with any system, there's a lot of change that's being undertaken on a very rapid basis, especially with some of the changing stressors on the system, i.e. hospital staffing, i.e. physician staffing, ambulance availability. It's a very dynamic process. But I think that there's definitely room and opportunity to have that conversation and have that on the table to be able to better equip some of our remote and rural paramedics to be able to provide the best care that we can, whether that's in a PFC setting, whether that's in a aeromedical setting, or whether that's however that looks for the that practitioner.
And I think we also need to roll out that concept, whatever label you want to put on it, to our nursing colleagues, particularly in these remote and rural areas. Because even as a paramedic, I'll admit the first 2 hours I got figured out pretty good. And when I'm working with my nursing colleagues, I hope I have an ICU nurse on my team at that time who can help bridge the hour 2 to hour 70 when the plane shows up. And I think if we can bring that training into the health authorities and the governing bodies for the clinics / sending facilities themselves, to our nursing colleagues would probably be the easier sell initially. Then they can set that patient up for success. And then if the paramedics also happen to have the same concepts, it should mesh together nicely. Because in my experience, and same with Greydon's flying into these remote communities, nobody really trains or educates people on how to set this patient up for success before aeromedical transfer. And you can give suggestions on the phone, but they're already operating at 100% stress level on 3 hours of sleep. So I think if we have one team, one goal, which is an old ambulance service saying, but really the whole province is one team. So why can't the team in the clinic interface with the other team on the ambulance? No need to be two separate entities in this concept.
That's the trick, isn't it? So both of you are going through our master's program. Tell the listeners why you chose to do our master's of austere critical care, and then how is this going to enhance your clinical practice?
I can't remember exactly how I stumbled upon the program. I think it was some of your smaller continuing education, like the minor illness course or something along those lines. And, master's degrees in paramedicine and PhDs in paramedicine are a relatively new concept, not so much for our colleagues down under and our colleagues in Europe, but that's an arbitrary number. There's probably only 100 master's level paramedics in Canada, and that number is probably generous. Correct me if I'm wrong, if someone knows, but it's new. And as I'm a stark advocate for paramedics, leading paramedics and advancing the profession, as we're starting to interface with other stakeholders, all of the other stakeholders have graduate level education. And if you want a seat at that table as a subject matter expert in your field, you also need to have that graduate level education. And this program specifically, the fact that it's a master's of science, not some quirky masters of something. At the core, it's a master's of science. So if we continue on to further grad school, it will benefit. And, everyone asks, what's austere critical care? And initially, I didn't know any more than the next person, but we kind of boiled it down to, if we can provide evidence-based ICU level care with minimal equipment, doing it with all the proper equipment should be relatively easy. And what I liked especially about this week is this isn't some side hustle of a company that's like, let's use sticks and triangular bandages and make a ventilator. Like, no, this is evidence-based, modern clinical practice with realistic expectations and realistic equipment. Because you're not all in a level 1 ICU in a 1 million+ city with all the help in the world.
And yeah, much like Cole, I was looking around for a master's program for a little while, and there's a lot of paramedic master programs, whether it's critical care or masters of paramedicine throughout the world, either in Europe, in Australia, even here in Malta. What really drew me was the fact that this is a global program, the fact that there are members from all over both North America, Europe, Asia, all over, and to be able to come together and share ideas on an international level, I think it's been an eye-opening experience for me so far. But getting back to it, that having a global view on paramedicine and not necessarily siloing in on how Canada does it, how BC does it, or how North America does it, has been hugely beneficial and was a big draw coming into it. The other big thing that drew me to the program was the significant amount of clinical time or opportunity for clinical time within a more remote or austere healthcare settings. So, for instance, Kabosha or KCMC, which is an opportunity I am incredibly looking forward to, and I think it's going to be a great challenge and a huge eye-opening experience.
So both of you guys have finished or going through the first three, the 701, 702, 703, and tell the listeners your experience of now that you're a third of the way through the program.
I still don't like writing papers, even back from my undergrad days. The other benefit to this program is the delivery model. Online education is the future, and med schools, if you're listening, figure it out. The ability to, in our downtime, the little of it we get in our profession, I mean, we get a little more than some of our colleagues, but to be able to self-paced and work through a program and not have strict deadlines is super, super beneficial. And who doesn't want to spend a week in Malta?
The experience so far has been fantastic. The big plus for me is self-paced. I will go through a couple weeks where I have a lot of time that I can put a lot of time and energy into the program and get through a bunch of modules. And there'll be times where I don't have that availability or don't have that bandwidth. And the time constraints surrounding each module are quite generous, which has been a huge benefit for me moving through the program at the pace that I have been. And like Cole said, who doesn't want to come down and spend a week in Malta? It's been an amazing experience here with the faculty and with our fellow colleagues and students.
And like you said, that international lens is perfect because, all of our problems are generally speaking the same around the world. And, why do we all have to reinvent the wheel when we can I think we have almost 11 different countries here this week, bringing their perspective from every corner of the world.
So you're here for your mandatory hands-on time in the ACC 703, 705 module and the iCare course, Intensive Care for Austere and Remote Environments. So tell the readers your experience so far on that course and how do you like it? And more importantly, how can it be improved?
It's been I came in this with a bit of an open mind, not knowing what to expect. I was really surprised at, first and foremost, the student ratios. There's a ton of well-rounded and faculty that are very dedicated and disciplined within their fields, which has been fantastic, and a very diverse group of faculty. So be able to have those one-on-one questions with the anesthesiologists, with the combat medics, has been huge. The opportunity to learn not necessarily new things, but learn different ways how to do what we've done previously has been an absolute game changer. And this is where that we always hark back to that global scope. The idea sharing that has taken place that I've seen from people in Hungary, from people in Poland, and all the different techniques has been hugely beneficial. And so the tight-knit cohort combined with the international scope, combined with the high instructor ratio has been just absolutely outstanding for both the ultrasound, the APIS course, as well as the iCares course. And we're really looking forward with great anticipation to the scenarios for our final day on Friday.
Yeah, I also agree with with the faculty being very diverse, but same with the students. the various disciplines we have. We have physicians, we have paramedics, we have nurses, and every version of in between. And I don't know if you've noticed, but there's times where the faculty kind of steps back and lets the group essentially educate themselves, because there's always high performers with lots of experience in every course you take. And, we have a subject matter expert on some particular topic. The faculty seems to support that learning transition or learning delivery of students teaching other students.
So the last question I had for that was, how do you improve this?
That's real tough, because I'm still processing all the amazing tricks and tips that I've learned from both the faculty and my peers. If anything, more time. As with anything, it takes a little bit of time to build in the concepts-based repetition and the muscle memory to make some of these skills second natures, or these thought processes second nature. And so the only thing I can really add is more time on the tools, more time in the dirt.
Yeah, like we talked about earlier, I think from the pre-mission planning perspective, it sounds like you have another course that covers all of this, but being able to do your pre-mission research and what you're looking for, how to look for it, more of that expedition medicine side of stuff, I'm presuming, but how to set your team up for success, because we take it for granted. Like, you go into a clinic for the first time. Okay, how much narcotics do I actually have? And then you do the math and figure out how long you can keep someone anesthetized. But also, like, from the security side of it, and having the 68 Whiskeys and the 18 Delta series, like all the guys who have seen combat and how they approach these problems and how they plan ahead to be ahead. Like, we don't have that experience, and we'll never get it, most likely. So it's nice having access to that. And you meshed military and civilian quite nicely.
I'm biased, I'll be honest. I designed the MSc Austere Critical Care with the soft medic in mind. And then we offered it to everyone, and now we're seeing that the majority, so it's 56 on the course, there's 10 soft medics. So obviously you guys have hit the ground running, haven't you? And you are picking up the learning and using it into your practice. So that's something I wanted to ask. How are you going to use this to enhance your personal practice?
I think from the approach, like, there's been, I liken it back to, again, those doing more with less, having well-defined thresholds, as well as, there's been a whole host of tricks and tips that have been taught this week. And the one that stands out to me was one of the faculty members showed us, I believe it was the Hungarian passive oxygenation method, which was simply a piece of O2 tubing placed through an MPA at 15 liters a minute to hyperoxygenate or pre-oxygenate your patient prior to intubation. And to me, that trick, that's something I've never seen before. And with the literature that I then read up on it, that makes a ton of sense. So there's all these little pieces that, we were aware of the concepts prior to, but how those concepts were taught and accomplished were taught in one system settings perspective. Getting other perspectives on different systems and how they approach that has been hugely invaluable. And that's one of those things that blew me away that I'm going to take back. I'm sure there's many, many other bits and pieces, but those are escaping me right now.
I think obviously ultrasound, it's the topic of the year for sure. And I don't know how people practice without it in formalized systems. The amount of diagnostics that you have in one hand is just incredible. And side note, we've had exposure to ultrasound in other critical care education, and the 20 minutes of the physician showing you where to stick the probe and look at the cool fuzzy pictures accomplishes nothing. Where your program, the ratio is beautiful, but it's not fighting over one ultrasound probe. You have all the scans you want. The accreditation with the Royal College is a nice little cherry on top, because we're trained at the same level. We take the same training the physicians do to do the skills, so it can't be questioned, which is important in our profession. And then practice-wise, we're so used to in North America, like being so OCD, and we have to have this specific tube goes in this specific hole with this specific type of tape. And if you've got them, smoke them, as they like to say. But realistically, it's a tube and a wire and a hole. And when you're in resource-limited environments, you work with what you got. Like peripheral femoral IVs, like I still don't think I've mentally processed. So doing more with less, and you seem to have perfected the balance of, okay, it's not duct tape and sticks. There's a place for that, but it's also not a metropolitan ICU. It's the happy medium.
You've already answered this, but what do you think austere critical care is?
I think austere critical care can really be summarized into being able to do more with less. I think that's one of the best summaries that you can really distill the concepts into. Doing more with less and being able to think ahead to be ahead, and understanding the repercussions of your actions within a setting where you don't necessarily have safety nets and large amount of resources at hand. And understanding that this patient may very well be your problem, not only for the next 2 hours, not only for the next 4 hours, but potentially the next 24, 2 days, 3 days, and really looking at things in a prolonged field care context, I think is what you can, if you were to take a couple concepts and distill it down, is doing more with less, and understanding that patient is going to be yours for the next several hours to days. And being prepared to do that, and understanding the repercussions of your actions and treatments should you decide to take some of those.
Yeah, I agree. So what austere critical care means to me is providing evidence-based clinical practice in suboptimal environments where help is nowhere nearby. And a quote that I sometimes remember to kind of mirror what you're saying is, a good surgeon knows when to operate. A great surgeon knows when not to. Like in your 911 role, intubation, it's a relatively easy decision at the end of the day. But in the clinic role, I find myself, and it's reinforced by this learning, like, maybe don't pull the trigger on that quite yet, because are you prepared for all the dominoes that are going down the road? So can you do more with less? And the nice thing about this program too is sometimes you have to pull that trigger whether you want to or not. So then how do we deal with the fallout? Planning and preparation, obviously, but in a perfect world.
So our topical travel expedition medicine course, which starts Monday, covers all the things you've been mentioned on medical intelligence assessment and expedition medicine and stuff. It's kind of why we offer them back to back, but that's why we didn't cover that this week, because we're doing it next week.
Fair enough.
Valid point on what austere critical care is. What do you hope to learn on your clinical experience in Tanzania?
That's, I think, an incredibly loaded question. And I think the best way to go in there is with an open mind. Being able to go in and with an open mind, quickly and efficiently integrate in with the existing team, understand the expectations of what our role is and how we integrate with the existing framework, like the physicians and the nurses and the other support staff that they have there, I think are going to be key things. And then from there, being open to understanding the challenges that they have, because the challenges that we have in North America are night and day difference to the challenges that they have in a sub-Saharan African context or in Tanzania at the base of Kilimanjaro. So I'm really excited to get to learn some region-specific medical issues and challenges, as well as just how that part of the world does business and does medicine. So those are going to be my big kind of takeaways that I want to take from our clinical placements in Africa.
Yeah, I agree. It's such a unique opportunity. It's, there's other programs out there, and it's seems a little medical touristy, in my opinion, and I don't think that should ever be the goal of an institution, and it's clearly not the goal of yours. One of the many reasons we are where we are here. We're not going to go there, and we're not going there to change the world, as everyone likes to say. That's their playground, their sandbox. They have perfected their system, and we're there as guests to integrate into their team and support them. We're not there to reinvent the wheel. We want to see how they put the wheel on the car and try to integrate that. Because what you said, our problems are not their problems and vice versa.
So you guys will be registering at Kilimanjaro Christian Medical Center. Do either one of you want to go 14 kilometers up Mount Kilimanjaro to Kabosho District Hospital?
We're both going to Kabosho.
Oh, you're just going to Kabosho?
We're spending our entire placement at Kabosho there. So we had a good chat with the faculty, and there's some more unique austere, more unique challenges for both austere care and as well as critical care. And it's a smaller bed facility, so we're looking forward to some of the challenges that come with the patient population, the demographics, the tourism that comes there to climb Kilimanjaro. So we're really interested to see the challenges of that hospital and how that interfaces in with its tertiary care centers, to which myself professionally, I'm very used to dealing with tertiary, high-level, high-functioning care centers. So to see somewhere that's a little more handcuffed into what they can and cannot do as far as services and level of care, I'm really looking forward to seeing how they manage to do the best patient care that they can with the tools and the services they have available to them.
Yeah, and I would recommend the listeners to listen to the Kabosho specific podcast that you have. I don't recall the specific provider that was interviewed. But you're right, the opportunities, I think KCMC has some wonderful opportunities. And it's nice you have both sites for people in varying stages of their career and trying to fit people in where they will succeed. And being able to work in that resource-limited environment, but still have that safety net and mentor net of the emerged physician, it's critical to the learning. So compared to other potential, like you don't want to show up and, well, there's people in the waiting room, go do your thing, because that's not how you learn. And that's not ethically appropriate either to the residents of that area.
Good deal. It's one of my favorite places in Africa, Kabosho, because being Irish, it's cooler and it's and you have different fauna, different and the view up there is spectacular. About 300 kilometers view, and I spent some time there before COVID ages ago, and immediately fell in love with it, but immediately saw that this would be a soft medic, perfect place to be, because they're kind of there on their own, and they're able to see a vast amount of people without 60 medical students looking over your shoulder. And so we have sent SF medics, we've sent SF docs, but we're now sending more of our advanced students there who are getting an amazing experience. So I look forward to hearing how you get on with Dr. Matero and the lads at the district hospital, and seeing the learning there is a bit different because it doesn't have as much money or facilities as KCMC. So it's definitely a district hospital, but man, what a fantastic experience you guys have in front of you.
That was, again, one of the big driving points to looking at this program over others, was the unique opportunity to go to a unique place to do some unique medicine and have an incredible experience while doing it, all while under the guise, quote unquote, of education and doing a master's program.
And the small numbers are nice too, to go back to what you were saying. Like, we've all done our times in large tertiary centers and have to push the gaggle of residents out of the way to be like, I get to tube twice a year, I need this one, thanks. So to be able to, it sounds like a pretty small, tight-knit team in that hospital, and hopefully we can integrate well into it and help at least make their workload a little bit easier.
So my final question is this: what advice do you have for the brand new paramedic, the new nurse, the new doc, anyone who is starting out on their career in austere medicine?
Tough question, because I'm still figuring it out myself, because we're always learning. I think that just because you're a new provider doesn't mean you can't do these jobs. I don't believe in the requisite number of years to do something if you have the right education and the right motivation and willingness to learn to do it. Look in the military, you're 19 years old off the street and then somehow you're an 18 Delta. So somehow that transition happens, and proper education is definitely the route. I think degree entry to practice for our profession is important, and other parts of the world have recognized that and have implemented it. And Canada, we're just in the implementation phase. And you need to specialize your education, just like physicians, nurses and paramedics have specialties. And even within, the advanced care paramedics like us, there's now every week, it seems like there's another subspecialty. And then you end up with specific education, such as with the college here, that remote paramedic practice is kind of a new term in Canada, even though we've been doing it for 100 years. It's at least now we have an institution that specializes in that. So go do the education and do your clinical placements, and you win some, you lose some, and that's how you learn. It's called clinical practice for a reason. And just don't think you have to be 10 years in to specialize and do this work. If you're motivated, fly at her.
I think my advice to the new provider going down this path, much like this was advice given to me early on in my practice, was the old adage, 2 ears, one mouth, always, and an open mind. It's been incredibly evident even here this week. There's a lot of reminders that you can still learn things from the first year bachelors of science remote paramedic students. You can learn things from our nursing colleagues who have worked in South Africa, who have worked on cruise ships and cargo ships. You can learn things from the U.S. emerge physicians. And likewise, there's been a few things that we've handed off to our colleagues here. So having an open mind, there's, they like to say there's 100 ways to skin a cat. Just because you have one way doesn't mean it's the best way. So take it with an open mind, be open to listening, and communicate and share the ideas that you have as well. Because there's an opportunity or a chance that what you've learned in your education process and your experience is not the same that others have. And maybe if you can convey one learning pearl, then you're paying it forward.
Well, Greydon, Cole, it's been fantastic to have you here for almost 10 days. And your insights are valuable. We appreciate you being on our master's program, and I appreciate you being on the podcast.
Thanks for having us.
Yeah, thanks for having us, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.